Picture this. A horse, vibrant and strong, suddenly succumbs to an invisible enemy, plummeting into a life-threatening emergency in mere hours.
It happens terrifyingly fast.
Today on the Deep Dive, we pull back the curtain on that invisible culprit, a silent, powerful toxin called endotoxin, and the devastating syndrome it triggers, endotoxemia. It's a story of internal chaos, really, where the body's own defenses turn rogue, and understanding it is just key to protecting our equine companions.
It's a profound challenge,
Yeah.
absolutely. Endotoxemia is a clinical syndrome where endotoxin, or LPS lipopolysaccharide, which is this potent heat-stable component from the outer wall of gram-negative bacteria, it somehow gets into the bloodstream.
Okay, so it shouldn't be there.
Definitely not. This can happen directly from severe bacterial infections, or, and this is critical, when damaged epithelial surfaces like the delicate lining of the intestine allow that free LPS to be absorbed.
Ah, like a leaky barrier.
Exactly. And once that happens, it kicks off this complex chain reaction. It interacts with blood components, activates inflammatory cells, leading to what we call an overzealous inflammatory process.
An overzealous process. That sounds dangerous. And that's our mission today, right? We're going to unpack the critical causes, the surprising, sometimes subtle signs, and the incredibly complex, urgent treatments for equine endotoxemia. We want to help you understand this formidable challenge in veterinary medicine.
Absolutely. It's crucial knowledge.
So we've set the stage with this invisible threat. Let's really dig in. What is endotoxin, this, tiny molecule, and why does it wield such immense power in a horse's body?
Well, essentially, endotoxin, LPS, it's an incredibly potent stimulus for inflammation in the horse.
Yeah.
You can sort of think of it as this tiny alarm bell that, once it gets into the bloodstream, triggers a massive overreaction.
Like the body panics?
Precisely. This chain reaction starts when LPS is absorbed, often through compromised gut linings, like we mentioned. Once it's in the bloodstream, it interacts with blood constituents and then gets recognized by specific receptors on the surface of inflammatory cells.
Okay.
This recognition triggers a really complex internal signaling pathway within those immune cells, essentially flipping a switch that unleashes a powerful pro-inflammatory response. It's the horse's own defense mechanisms, which are meant to protect, becoming, dangerously overzealous.
That sounds incredibly intricate. Is there a common misconception about how fast this chain reaction actually progresses, or maybe how subtle it can be in the early stages before it becomes this full-blown systemic crisis?
That's a really excellent question. Yeah, one common misconception is that it's kind of a slow burn. But in reality, once that switch is flipped, the cascade can progress incredibly rapidly. The body just unleashes a storm of powerful inflammatory chemicals, things like cytokines, TNF, interleukins, prostaglandins that just amplify the response. It's a cascade of signals, each one pushing the body further into crisis.
And the effects are widespread.
Oh, absolutely. The main effects are systemic: damage to blood vessels, significant changes in blood flow, activation of white blood cells, clotting abnormalities, and ultimately the state of profound shock and potential organ failure.
So that's where SIRS comes in.
Exactly. When we talk about the clinical manifestation of this systemic inflammation, we often refer to it as systemic inflammatory response syndrome, or SIRS. It's the body's entire system just going into overdrive.
So this isn't just a localized problem then, is it? This inflammatory storm can truly rage throughout the horse's entire body. Where does it tend to hit hardest?
Definitely not localized, no. It impacts multiple critical body systems, and it really demonstrates that precarious balance of the immune system. In the cardiovascular system, for instance, you'll see reduced heart contractility.
So the heart doesn't pump as well?
Right. And along with that, damage to the blood vessel lining that leads to something called permeability changes.
Leaky vessels, you mentioned.
Exactly.
Yeah.
Leaky vessels, fluid leaking out of the bloodstream into tissues, and potentially a severe clotting disorder called disseminated intravascular coagulation, or DIC. We'll probably talk more about that.
Okay.
For the gastrointestinal system, impaired blood flow to the gut lining can cause the tissue to actually slough off, creating more damage and allowing even more bacteria and LPS to leak into the bloodstream. It becomes this vicious cycle.
Oh, wow. So the problem feeds itself.
It really does. Then there's the hepatobiliary system. That's the liver and gallbladder. It can suffer from reduced blood flow to the liver, hepatic ischemia, leading to enzyme increases and altered liver function.
Yeah, the renal system.
Reduced blood flow there can unfortunately result in acute renal failure, where the kidneys just stop working effectively.
And the lungs.
And finally, yes, the respiratory system. It can experience pulmonary edema, which is fluid building up in the lungs, and even pulmonary thromboembolism, which are, blood clots in the lungs.
This raises such an important question. If endotoxin is the culprit here, what are the primary scenarios that allow it to get into the bloodstream in the first place? It sounds like the real battle isn't just fighting the endotoxin itself, but like playing detective to find and fix the root cause.
That's a crucial insight. Absolutely. And what's fascinating, or maybe alarming, is that endotoxemia is always secondary to a primary disease. It never just appears out of thin air.
Always secondary.
Okay. Yes. The most common and frankly significant causes are gastrointestinal disorders. Think of conditions like severe colic with ischemia or strangulation, where the blood supply to a piece of the intestine gets cut off, maybe due to twists or displacements.
Right, the classic surgical colic.
Exactly. That leads to tissue death and a massive leakage of endotoxin from the normal gut bacteria. Then there's colitis, or severe diarrhea, where inflammation of the colon, perhaps from things like salmonella or Clostridium difficile, directly damages the intestinal lining, making it permeable to endotoxin.
So inflammation itself opens the door.
It does. We also see it with proximal enteritis jejunitis, often called DPJ. That's an inflammation of the upper small intestine causing ileus, meaning the gut essentially just stops moving, which leads to significant endotoxin release.
So the gut just sits there stewing.
Pretty much. And even something as seemingly simple as grain overload or carbohydrate overload, where excessive fermentable carbs cause bacterial explosion and gut damage, that can trigger it too. And though it's rare, gastric rupture is another potential cause.
So it's not always some dramatic twist. It could actually be something like an accidental dietary mistake. Are there other common, maybe less expected sources of endotoxin besides these GI issues?
Yes, absolutely. Reproductive disorders are also quite significant. A very, very common cause in mares is a retained placenta after foaling. If the placenta isn't expelled fully, it quickly becomes infected, releases endotoxin, and causes a severe metritis or uterine infection.
Ah, I've heard of that being dangerous.
It is. And really, any severe metritis can be a trigger. Respiratory disorders can also lead to endotoxemia, particularly severe bacterial infections of the lungs like pneumonia or pleuritis, especially those involving gram-negative bacteria. You sometimes hear it called shipping fever.
Okay.
Then, tragically, there is neonatal sepsis in foals. This is especially common in foals with failure of passive transfer, FPT, where they don't get enough maternal antibodies from the colostrum. They become highly susceptible to systemic gram-negative bacterial infections.
So they're just unprotected. Essentially, yes. And other systemic infections like peritonitis, cellulitis, deep abscesses, or even severe trauma and burns can also act as triggers. What's important to remember really is that horses are particularly susceptible to sepsis coming from GI disease, metritis, pneumonia, and neonatal sepsis, especially with FPT or high-risk pregnancies. It truly highlights how an infection in one specific area can rapidly become a systemic crisis.
So, okay, knowing all these potential causes, how would you or how would an owner know if a horse is actually in the throes of this really serious condition? What does it look like? What are those, undeniable, visible clues that tell us a horse is in deep trouble? Maybe that aha moment for a vet.
Well, the clinical signs are a direct result of that systemic inflammatory cascade we talked about, and they can really range from quite subtle early signs to life-threatening severe ones. Initially, you might just observe a fever. Although, interestingly, in severe shock, it can paradoxically progress to hypothermia, a low body temperature, which is actually even more concerning.
Oh, okay. So a low temp can be worse than a high one here. In this context, yes, it often indicates circulatory collapse. The horse will usually appear depressed, lethargic, just not themselves, and experience a significant loss of appetite, anorexia. They might also show signs of mild to moderate abdominal pain, colic signs.
And what about the more visible sort of telling signs, the ones that truly jump out at you?
Right. One of the most striking changes, and something you should really look for, is in the mucous membranes, the gums, inside the eyelids. Initially, they can be bright red or hyperemic, which is due to vasodilation. But as shock develops, they progress to this brick red, purplish, or even cyanotic bluish tinge.
Wow.
And often, you'll see a distinctive toxic line develop on the gums just above the teeth. This toxic line is basically an alarm signal, indicating profound circulatory collapse.
A clear visual cue, then.
Very clear. You'll also see an increased capillary refill time, CRT. If you press on the gum and it takes longer than 2 seconds for the color to return, that indicates poor blood flow. Blood isn't getting to the tissues quickly enough. The horse's heart rate will be increased, tachycardia, and their respiratory rate will also be up, tachypnea. You might listen to the gut and hear decreased or absent gut sounds, indicating ileus. And depending on the underlying cause, diarrhea may or may not be present. In some really severe cases, you might even see peripheral edema, which is swelling in the limbs or the lower abdomen as fluid starts leaking from those damaged vessels.
And when it truly becomes a desperate situation, like the horse is crashing, what does that look like?
When it becomes severe, the signs point towards profound shock and organ dysfunction. The horse will show profound depression, often becoming almost unresponsive. Their extremities, their legs and ears will feel cool, and their rectal temperature may become subnormal, signaling that circulatory collapse is happening. Blood just isn't reaching the periphery.
That sounds critical.
It is. The tachycardia will be severe, but the pulse, if you can feel it, will feel weak and thready. It reflects the body's desperate attempt to circulate blood, but it's failing. They may be unable to stand, becoming recumbent, lying down, and you might see muscle tremors.
And you mentioned laminitis earlier.
Yes, a truly devastating complication, and unfortunately a common one, is laminitis. It's characterized by intense pain, heat in the hooves, and strong, bounding digital pulses, leading to severe lameness. This is often the complication owners fear most, and rightly so. It can be career-ending or even life-ending.
You've painted this picture of widespread systemic effects, and a truly serious complication that often surfaces is DIC. Can you maybe explain that truly devastating complication a bit more?
Yes, disseminated intravascular coagulation, or DIC, is a severe bleeding disorder that's a direct consequence of this whole inflammatory storm. Basically, the body starts forming widespread microscopic blood clots throughout the small vessels.
Clots everywhere.
Tiny clots, yes, everywhere. And this process consumes all the vital clotting factors. So paradoxically, it leads to both abnormal clotting and hemorrhage, or bleeding.
How does that show up?
You might see tiny pinpoint hemorrhages called petechiae on the mucous membranes, or notice bleeding from injection sites that just won't stop. Ultimately, these severe signs can progress to multi-organ dysfunction syndrome, or MODS, affecting the kidneys, liver, and lungs, leading to complete organ failure and, tragically, often death.
And for foals, are the signs different?
For neonates specifically, the signs can sometimes be more subtle initially. Things like decreased suckling, profound weakness, they often just don't look right, as people say. It requires really close observation.
So, okay, if you see these critical signs, how do veterinarians actually confirm it's endotoxemia and not something else entirely? What does the diagnostic process involve to get to that definitive answer?
Well, the diagnosis usually starts with a strong clinical suspicion, right? Based on the primary disease process, like that severe colic or the routine placenta, combined with the presence of those specific clinical signs we just discussed, like the toxic line or the CRT.
So history and physical exam are key.
Absolutely fundamental. Then, laboratory findings become crucial, both to confirm the suspicion and to gauge the severity of the situation. A complete blood count, CBC, biochemistry panel, and urinalysis can reveal a lot.
What kinds of things show up there?
Initially, you might actually see a neutropenia, meaning a critically low neutrophil count, sometimes even less than 1,000 cells per microliter. This indicates the immune system is being overwhelmed, and those neutrophils are rushing out of the bloodstream to fight the inflammation in the tissues.
So a low white count can be bad here.
Very bad sign initially, yes. This is often followed later by neutrophilic leukocytosis, a high count with a left shift, meaning lots of immature neutrophils are being released from the bone marrow too quickly. You also usually see hemoconcentration, meaning an increased PCV and total plasma protein, mainly due to dehydration, although sometimes the plasma protein can decrease if there are significant losses from the gut.
And organ damage markers?
Yes. You'll often see high liver enzymes and bilirubin, indicating liver injury, and azotemia, which is increased BUN and creatinine, because of kidney issues or just severe dehydration impacting kidney function. Blood sugar can be a roller coaster, initially high, then potentially dropping to dangerously low levels, hypoglycemia, as the body uses up its reserves.
And for a condition impacting clotting so much, I imagine specific coagulation tests are absolutely key.
Absolutely essential. A coagulation profile will typically show things like prolonged clotting times, APTT, EPT, increased fibrinogen degradation products, FDPs, a low platelet count, thrombocytopenia, and decreased levels of fibrinogen and antithrombin III, all direct evidence pointing towards DIC.
Okay.
A blood gas analysis is also really important. It often reveals hypoxemia, which is low oxygen in the blood, and metabolic acidosis, usually due to poor peripheral perfusion and lactic acid buildup from tissues that aren't getting enough oxygen.
Is there a specific test just for endotoxin?
There is. While these clinical and lab findings are usually enough to make the diagnosis and start treatment, a chemiluminescent endotoxin assay can measure endotoxin activity directly in the blood. It's just less commonly used for immediate clinical decisions in the field or even in many hospitals.
And ruling other things out.
Right. Differential diagnosis is important. You need to consider other forms of shock, like hypovolemic shock from fluid loss or cardiogenic shock from heart failure. The comprehensive lab work really helps differentiate these. Finally, diagnostic procedures like aerobic and anaerobic blood cultures are vital to try and identify any underlying bacterial infections, which can help guide specific antibiotic choices down the line.
So what does this all mean for treatment? I mean, given how complex and fast-moving this condition is, it really sounds like a true race against time. What are the key strategies to fight it?
You're absolutely right, it is a race. Treatment is a critical medical emergency, and it almost always requires immediate referral to an equine hospital because of its multifaceted nature and the need for intensive 247 care. Prevention, if possible, and quick action are truly ideal.
And the first step?
The single most crucial step, above absolutely everything else, is eliminating or controlling the source of endotoxin. You have to stop the leak.
Makes sense. Like what?
For example, if it's colic involving a twist in the gut, that likely means emergency surgical correction. For a mare with a retained placenta, it means aggressive uterine lavage, flushing out the uterus, and antibiotics. For neonatal sepsis, it's aggressive intravenous antibiotics to fight the infection. If you don't remove or control the source, you're constantly fighting a losing battle against the continuous influx of endotoxin.
Right. You're just bailing water out of a sinking boat if you don't plug the hole. So once that source is addressed or being addressed, what's next in this complex battle plan?
Okay, next, fluid therapy and cardiovascular support. These are the absolute foundation of treatment. Restoring circulating blood volume is paramount. We use large volumes of balanced electrolyte solutions, like lactated Ringer's solution, intravenously.
Just flooding them with fluids.
Well, large volumes, yes, but carefully. You have to be cautious to avoid overhydration, especially in foals or in horses that have low plasma protein levels, because the fluid might just leak out into tissues.
Right, those leaky vessels again.
Exactly. So sometimes we use colloidal solutions like hetastarch or plasma, which contain larger molecules that help keep fluid inside the blood vessels, particularly when plasma proteins are low. Hypertonic saline might be used for rapid but temporary volume expansion in severe shock. And sodium bicarbonate can be given carefully to treat severe metabolic acidosis.
What about supporting the heart and blood pressure directly?
In cases of severe shock where blood pressure remains low despite fluids, we might use inotropic agents like dobutamine to help support heart contractility and blood pressure, though their use requires very careful monitoring. And of course, oxygen therapy is critical if the horse is showing signs of respiratory distress or low blood oxygen levels.
Okay, fluids and support. Then what about directly targeting the endotoxin or that devastating inflammatory cascade it causes?
Right. So to inhibit further endotoxin release, broad-spectrum antimicrobials are often started early, ideally after blood cultures are taken. Certain antibiotics, like amidoglycosides or carbapenems, are sometimes suggested because they might cause less LPS release when they kill bacteria compared to others, although this is still debated. And of course, removing infected tissues surgically or draining infected fluids helps stop the release.
And then blocking the inflammation itself.
Yes, blocking the inflammatory cascade and combating those inflammatory mediators is a major goal. NSAIDs, nonsteroidal anti-inflammatory drugs, are key here. Flunixin miglumin, Banamine, is the most commonly used and is considered a potent anti-endotoxic NSAI.
Okay.
It's often given at a specific lower anti-endotoxic dose, like 0.25 millijoule kilogram IV, rather than the full anti-inflammatory dose. The idea is to block the effects of endotoxin while trying to minimize the significant side effects of NSAIDs, like GI ulcers or kidney damage, which are a major concern, especially in sick, dehydrated horses. Furocoxib is another option sometimes used.
You mentioned corticosteroids are controversial.
Very controversial, yeah. Low-dose corticosteroids are used in human septic shock protocols, and some studies suggest increased survival. but high doses are generally discouraged in horses. Their overall benefit in equine endotoxemia is still really being determined, and they might even be contraindicated or harmful in cases with severe ongoing infections or if the horse is already showing signs of laminitis.
So it's a tricky balance.
Extremely tricky. Other agents sometimes used include pentoxifylline, which can help modulate inflammation and improve microcirculation, blood flow in tiny vessels, and DMSO, which is a free radical scavenger and has some anti-inflammatory effects. These are often used as adjuncts, sort of supporting therapies.
And what about actually like mopping up the endotoxin that's already circulating in the bloodstream? Is there anything that can directly scavenge it?
Yes, this is where polymyxin B comes into play. It's technically an antibiotic, but its main use in this context is its unique ability to bind directly to and neutralize the lipid A portion of endotoxin, which is the toxic part.
Oh, interesting. So it grabs onto it.
Exactly. However, polymyxin B itself can be nephrotoxic, meaning damaging to the kidneys, and potentially neurotoxic. So extreme caution is needed, especially in dehydrated patients or those with pre-existing kidney issues. Using a specific formulation, a dextrin 7D conjugate, can apparently help reduce its toxicity. It's an important tool in the toolbox, but it's worth noting its overall efficacy in clinical equine cases hasn't been as critically evaluated through large studies as some other treatments.
Any other scavengers?
Well, there's also hyperimmune plasma. This is plasma collected from horses that have been repeatedly vaccinated against the core part of the LPS molecule, often using a specific bacterial strain like J5 coli. The idea is to provide preformed antibodies that can bind to and neutralize circulating endotoxins.
Does it work?
The results are variable. Its efficacy has been pretty controversial and inconsistent in studies. Some reports suggest benefit, others show none, so it doesn't seem to work reliably for every horse, and it's quite expensive.
Okay. So beyond fighting the endotoxin directly, how do veterinarians actively try to prevent those disastrous complications you mentioned earlier? Things like laminitis or DIC. It really sounds like those are huge battles in themselves.
They absolutely are. Preventing complications is a massive part of the overall battle plan, often just as important, if not more so, for long-term outcome, as treating the primary issue itself. For laminitis prevention, aggressive cryotherapy is probably the most effective thing we can do.
That's icing the hooves.
Exactly. Continuous icing or soaking the hooves in ice water to keep them profoundly cold. This, along with NSAIDs for pain and inflammation and providing proper mechanical foot support like deep bedding or special shoeing, are all vital. Early and aggressive cooling seems to make a big difference.
And for DIC, that sounds terrifying to manage.
It is. For DIC management, it involves very cautious use of anticoagulants like heparin, trying to prevent those microcots from forming while simultaneously managing the bleeding risk. Plasma transfusions might be needed to replace consumed clotting factors and antithrombin III. It's a real balancing act.
What about the gut itself?
If there's ileus, where the gut stops moving, and reflux fluid backing up into the stomach, then gastric decompression through a nasogastric tube is absolutely necessary, sometimes needing to be done repeatedly, to prevent the stomach from rupturing, which is almost always fatal. Gastroprotectants, like sucralfate or omeprazole, are also usually given to horses receiving NSAIDs to help protect their delicate GI lining from ulcers.
And getting them eating again.
Yes, nutritional support is crucial for recovery. Once the gut seems stable, it involves a very gradual reintroduction of feed, often starting with small, easily digestible meals. For horses that can't eat for a prolonged period, parenteral nutrition, providing nutrients intravenously, might be necessary, although that's complex and expensive. It truly is an intensive, multi-pronged, moment-by-moment approach.
Wow. So once a horse is undergoing this incredibly intense treatment, what does the recovery actually look like? What are the possible hurdles they might face, even after the immediate crisis seems to be addressed?
Well, first off, the monitoring has to be relentless, and it's important to understand that the prognosis for endotoxemia is generally guarded to poor, which really highlights the severity of this condition.
Guarded to poor, that's sobering.
It is. We're closely monitoring vital parameters, heart rate, respiratory rate, temperature, mucous membrane color, CRT essentially around the clock, plus blood gas analysis, pulse oximetry to measure oxygen levels, and frequent blood work checks, PCV, total protein, electrolytes, liver and kidney enzymes, BUN, creatinine.
And the hurdles, the complications.
The possible complications are numerous and frankly devastating even after the horse seems to be stabilizing initially. We worry about chronic laminitis that can become crippling, persistent electrolyte and acid-based disturbances that are hard to correct, pulmonary edema, fluid in the lungs, pulmonary thromboembolism, clots, ongoing DIC, persistent renal or hepatic dysfunction, continued GI ischemia or damage, vasculitis, inflammation of blood vessels, peripheral edema, and even sudden cardiac arrest.
So many potential landmines.
Exactly. The prognosis really hinges on several factors. The severity of the underlying cause that allowed the endotoxin in, how long the horse was exposed to significant levels of endotoxin before aggressive treatment began, and crucially, whether those severe complications like laminitis, DIC, or multi-organ failure develop.
So time is absolutely critical.
Time is everything. Early recognition by the owner or handler, prompt veterinary intervention, and aggressive, appropriate treatment are truly paramount in improving the chances of survival and minimizing the risk of those devastating long-term impacts. It's definitely a marathon, not a sprint, even once the immediate life-threatening danger seems to have passed. Recovery can take weeks or months, and some horses never fully return to their previous level of health or performance.
So after this really comprehensive deep dive, I think we have a much clearer picture of the silent but truly devastating nature of endotoxemia. It's triggered by these gram-negative bacteria and their LPS, unleashing a systemic inflammatory storm with potential multi-organ consequences and demanding immediate, aggressive, and multifaceted treatment. It's a stark reminder, really, of how quickly a seemingly contained issue can spiral into a life-threatening emergency for a horse.
Indeed, it highlights the incredible power of this single molecule, LPS, and the body's complex, sometimes self-destructive response to it.
Which leads to maybe a final thought for you, our listener, to ponder. Considering how the body's own immune response, which is meant to protect, can become so dangerously overzealous in cases of endotoxemia, what does this tell us about the delicate, intricate balance within complex biological systems? And perhaps how might understanding this better push the boundaries of future treatments, not just in horses battling endotoxemia, but maybe even in other species, including humans facing similar septic conditions?